So it gives me great pleasure to introduce our next speaker. So he's coming up to the stage right now. So Dr. Sundeep Kaul, a friend and colleague from the United Kingdom. So Sundeep is consultant in intensive care, respiratory medicine, and divisional lead for respiratory at Harefield Hospital in the UK. In case you don't know, Harefield Hospital is one of the UK's foremost centres for heart and lung transplantation. And Sundeep is going to talk to us today about refractory vasoplegia, current options, and next steps.
Good afternoon. Oh my God. Can you hear that? Can you hear that okay? Is that all right, John? Yeah? Well, good afternoon, everybody, and thank you for the for the fantastic opportunity to come and spend some time with you all. These are golden moments where we can share pearls of information and educational interaction. Thank you, Jaffron, for organising such a fantastic summit. I'll get this right in a minute. Is it this one?
No, this one is page 5.
Ah, got you. Thank you. Those are my declarations of interest. So I've got 19 minutes and 15 seconds, and it's counting, and I understand that it's only Antoine and me between you and lunch, so let's get you to lunch as fast as we possibly can. As John mentioned, I work at intensive care at Harefield. We're a cardiac centre. I'm an intensivist, lung intensivist, sitting in a heart centre. So I'm just going to go through what the issue is in terms of refractory vasoplegia is, what the current options are, and then what our personal experience is, and what I believe the next steps for the future development in this area should be. So what's the issue? Well, it's known to everybody. This is a state of vasodilatory shock. It's characterized by hyperperfusion due to a reduction in vasomotor tone, resulting in a decrease in SVR. The etiologies are diverse, but they ultimately end in low blood pressure, and there are lots of criteria. And I think one of the problems we have is that our criteria aren't standardized. So here's one I've picked from a recent recommendation, but bottom line is you've got low blood pressure, you can put the numbers and adjust them as you want, you've got low SVR, you've got high normal cardiac index, normal reduced filling pressures, and of course, very importantly, you have an increased need for vasopressors having filled the circulation. In my practice, the main place where I look at this is, or where I confront this, is cardiovascular surgeries, post-cardiac bypass. And you've heard about this elegantly from colleagues today. And it looks like a syndrome that is similar to sepsis. Bottom line is, there's an escalating requirement for vasopressors, and there's a higher incidence of morbidity and mortality of these patients. But who are these patients? We've talked about patient selection. So there are pre-op risk factors, renal failure. I should go and tap into John and say, John, is every renal failure patient who undergoes cardiac bypass going to have it? People who get ACE inhibitors and beta blockers, particularly on the morning of their operation, I mean, that's never going to be helpful. The surgeon will not like me if that happens. People with a slightly higher BMI. Clearly, endocarditis is a well-recognized risk factor for obvious reasons. We have a big population of LVADs. LVADs can have biofilms. You put them on bypass, boom, it goes off like a bomb. And of course, being male, I can't do anything about that. And of course, growing older is another bit of life. It's one of those things. Perioperative and postoperative parameters. My surgical colleagues tell me, the longer your surgery, the longer the bypass time, the more chance you are going to have of vasoplegia postoperatively. The more your blood transfusions, the redo surgery, the higher the chance of having vasoplegia afterwards. And I've had to deal with this for about 15 years, and I still don't seem to be that much closer than I was before I started. Initial treatment is basic, but obviously if you do the basics well, then the rest takes care of itself. So fluid resuscitation and get the vasopressors on as soon as you can. But my God, there's a combination of these things. I mean, who uses what and where? And what do we mean by refractory? Do we mean refractory to conventional dose of vasopressors and noradrenaline? I mean, we think high noradrenaline is 0.2. My colleagues, some of them think it's 0.5. Others go to 1 mic. Some go to 2 mics. So what is that dose? And we need some agreement on that. One thing I find that's missing is the heterogeneity, not just in diagnosis, but also in establishing the treatment. Steroids, is it before, is it after steroids? Methylene blue, out of interest, who gives methylene blue here? Show of hands. It can't just be two of us. Tell me I'm not the only person here. Oh, there's three of us now, okay. Only five of us, okay, so methylene blue. And so this makes the point. Clinical practice varies hugely, and it needs definition, it needs agreement, it needs consensus. It doesn't have to be, and of course, personalization will come afterwards. But to do a study and to understand what groups are going to benefit and how, we need to have a bit of an agreement on what those terms actually mean. Of course, angiotensin II is out there just to cause even more harry-carry for us. So current rescue options are high-dose noradrenaline, whatever that means, the use of vasopressin, adrenaline, again, angiotensin II, steroids, there's methylene blue, and of course, there's extracorporeal blood purification, which is why we're all here today. And just simply for me, does anybody use ascorbic acid, thiamine, and hydroxycobalamin? Anybody? No? Okay. Because I don't either. Okay, so here's a bit of our madness, and I'll share some of our experience with you in terms of methylene blue first, and then extracorporeal blood purification thereafter. So, great bit of work by Oliverio and Alessandra. I can't claim the credit for doing the data. They sacrificed themselves trying to find this stuff. I'm looking at 125 patients over a period of about 5 years who received methylene blue. 28 patients got it in theatre. My jurisdiction starts in ITU, but we put them all together. And just some top-line stuff. We used it in about 60 to 62% of patients for our experience is in post-cardiac surgery vasoplegia. Did they have low filling pressures? Well, one of the problems we have, of course, is in post-cardiac surgery is tamponade and diagnosing it. And you can't do it by guesswork. You need to have a PA catheter in there, you need to have echo handy, and you need to have constant surveillance. So actually, we were pretty sure in at least 2/3 of the patients that that's what they had. Did they require us? The most of them got the right dose, but another 25% got a second dose, which is interesting. And then most of the patients did not have a contraindication to methylene blue, but about 13% did, and they still got it. So this just shows you the level of desperation one achieves or is faced with when you're in that clinical scenario. And I think it's testament to that. So what was the overall survival of these patients? Of course, this is audit data, is 38%. So 38% left the unit. Interestingly, 14 of those patients were bilateral lung transplant, and they did particularly well, 71%. So I'm not sure what the reason is, but it does throw up a few ideas and thoughts. Extracorporeal blood purification. Well, yes, it's about cytokine removal. It's about removing those inflammatory mediators. And what's the idea from a clinical perspective? The idea is restoration and maintenance of hemodynamics and, of course, the metabolic status. That is the clinical syndrome that I'm faced with. Despite this being around for many years, and a lot of experts here being here, there's still a lot of opposition to this, even in my own unit. There's 14 of us, but there'll be 3 or 4 of us who are advocates, because people don't feel that there has been enough, if you like, due diligence done in terms of RCTs and, of course, patient outcomes. And I think that's really where we're going with this. So we've used Cytosorb, and we use Oxyris, and we've used HA330, and more recently, 380. So I'm just going to share some uncontrolled, real-life data set with you. And as I mentioned, the syndrome is the same. It's vasoplegia, plus or minus hyperlactemia, and it's in the context of mainly bypass, but also there'll be some SIRS and sepsis in there because of infection. Those are the first 18 patients, and you can see there's a whole selection of initial reasons why they come. There's a couple of patients with COVID, there's a patient with empyema and sepsis, but overwhelmingly, there's this whole idea of post-bypass surgery, whether it's double valve, whether it's pericardectomy, whether it's grafts, or whether it's aortic dissection. And these are the endpoint of the metrics that matter to me. When I'm in the ICU, this is what I'm looking at. I mean, I would love to have IL-6. I would love to have IL-8. I'd love to have IL-10. TNF-alpha. I have none of those. I have this. So this is what I'm using as my indicators to share with you where we get to. So lactate prior to starting, lactate at 24 hours, mean time to achieve 50% reduction in lactate, what's the vasopressor dose before, what is it at 24 and 48 hours, and the time taken to reduce that by 50%, the mean duration of HA330, or whichever HA we're using, what is a 72-hour survival, and there's a reason for that, actually. And obviously the percentage of surviving to discharge is that I don't know whether 4 weeks survival is actually linked to giving absorption therapy. I think it's a difficult one. I think you can link short-term survival. I think long-term is difficult because so much happens to the patient. I mean, I can't blame an intracranial bleed or sepsis on something that happened, a long time ago. So it's just one of those things. I think it's worth putting that into the equation. In this group of 18, there's a caveat. Not everybody had a raised lactate. So looking at the 18, and I'll break it down in a minute. The mean lactate was 4.6. You can see the range. It's quite broad. And after about a day or so, it drops to 2.4. And the mean time to achieve 50% reduction in lactate is about just over 1 day. The NORAD starting dose is 0.24. You may think that's too little. You may think it's a lot. Who knows? But the mean time to achieve 50% reduction was about 39 hours. And notice, in 2 people, the vasopressor requirements actually increased. So again, this is a heterogeneous population. Vasopressin. Mean starting dose was 0.04, and it took about 48 hours for 50% of that to get down to half. So hopefully we're getting a bit of a feel for what's going on here. And in terms of the mean duration of HA330, it was over a day, almost day and a half, something like that. 72-hour survival was 94%, and the crude ICU discharge was 50. If I just pick the 9 on its own, so I'm being extremely unscientific, open to provocation here, but if I just look at the 9 who just were hyperlactemic, then that's what they are. Again, it's mainly post-bypass. In those 9, the mean time to reduce 50% lactate was 11 hours versus 25, incidentally. The reduction in NORAD was about the same, 34 versus 39. The reduction in vasopressin was a little better, actually. In 48 hours, you hit 64%. And then, of course, the duration was about the same of HA330, slightly less. The 72-hour survival was 100%. And the ICU discharge was a little bit lower. It's about the same, 44%. Now, since then, we've had another 9 patients. And this is hot off the press. So one of my poor registrars has been trying to get this off while I've been with you. And so forgive me, this is in unstructured format. However, it presents a little bit more data, and it's in slightly different patients. So 3 are heart transplants, 1 is an LVAD, 2 is cardiac surgery. Again, you'll see it's mainly post-bypass. That's the population. 2 are post-impeller. They got a big inflammatory response to the sepsis, mainly pneumonia. And of course, 1 was vasoplegia post-via ECMO removal. And we do it again. The mean lactate was 4. And this time, I just note that our range is a bit narrower. And I just wonder if in the last year, we've gone a bit earlier. It's just a thought process. The lactate at 24 hours is 9. Is 1.4. So it takes about 8 hours to get it down in this group. The NORAD dose at 50% reduction took about 40 hours. Again, there was 1 patient, and I think that was the ECMO patient, where things went the other way briefly. Oh. The mean duration of our absorbent therapy was 36 hours. The 72-hour survival rate was 100%, and only 2/3 made it to ICU discharge. So I can't make any claims here. This is still hypothesis generating. It is raw data, but it does provide, hopefully, plenty of material for a randomized prospective control study. So what I think should be happening, I think we should be moving from this observational data to RCTs. I think we can use post hoc analyses and retrospective reviews to generate hypotheses, but be used to design studies, and carefully design studies with a more targeted focus. I think you can get fantastic data from RCT, but the power of the real life should never be underestimated. I think standardization of practice, now we've come to this before, is really important. I mean, yes, etiology, but sepsis, as my colleague said earlier, and I think it was Antoine, is heterogeneous. So you need to be very specific about which bit of it and when. Looking at the treatment, how much we give, the duration, there's already been plenty of advice on maybe 6 hours versus 12 or 24 hours and going early in sepsis. And then how do you sort out the confounders? In my domain, people have cardiac tamponade and they're vasoplegic, and I need to ensure that that is removed from the equation because it will confound the results. So it's quite important we get that right. Hemoglobin, fluid balance, and of course other rescue therapies that could confound the issue. Going back to each vasoplegic syndrome, I mean, when we look at endpoints for these patients, we've got to be a bit careful because, what is the role of each treatment in each syndrome? And I'll give an example. If you look at abdominal visceral perforation, the surgeon is involved. There's antimicrobial therapy, which could be fungal and antibacterial, and of course, there's adsorption therapy. In pneumonia, there's ventilation and antimicrobial therapy. And antimicrobial therapy in pneumonia is the one that does the heavy lifting. It does most of the work. But in post-cardiac surgery, it may just be that the absorption therapy is the main therapy of note here. It may be that's doing the main heavy lifting. And see, the size of the signal within each syndrome can be quite different. No child is the same. In the same way, no vasoplegia is the same. And of course, they will have common outcomes, which are survival, length of stay, development of renal failure, but then they'll have specific outcomes, depending on which part of vasoplegia you're looking at. I think we need to go from just cytokine, but to have them hand in hand with physiological and patient-centered metrics, and I'm pleased to see that shift occurring. I think that's really important. Where I come from, I can't get anything through the door if it costs. So I need to see the cost-benefit ratio. I need to see the financial outcome. Physiology and patient is crucial to me. A fantastic slide by Professor Claudio earlier today showing the ethical versus the economics. But in the real world, if they don't say yes, we don't get it. I can't do ethics unless the economics work. So we need to look at the data really well. The safety, and I'm looking forward to Antoine's lecture next. I want to know that I don't put an intervention in, reduce the antibiotic level, and then cause a bigger problem than I had to begin with. So I need to know that when to give stuff, what to do, and if that's in an evidence-based guideline of some sort of recommendation, then this empowers us to make the right move at the right time. We need to know what the numbers to treat are, to save life, to prevent dialysis, and of course, going home. And I quote this article. It was a guideline I read recently, and the bottom line is, it says that despite this being a common issue that you and I face on an every week basis, if not an every day, there's no major evidence-based guideline out there. And I appreciate the consensus recommendations from last year, but something that you can actually build on, which highlights the research gaps and says, hey, you've reached this level, now the next step is to answer this question. I think would be really helpful. So in summary, and I hope I've made up some time, refractory vasoplegia is a common clinical scenario. It carries a high level of morbidity and mortality. Our initial clinical experience with cytokine absorption therapy has been actually very encouraging, but it poses more questions than it answers. I think we need to get on with prospective studies. I think we need to have the right outcomes, the right metrics, which is patient-centered, and you need to give me the financial data as well. And I think it's really important that we evolve the study design if we are to capture and quantify the signal, thereby personalizing patient care. It is this that helps. It is the global multi-stakeholder collaboration that is the ticket to success here. And I look forward to exciting times as we push forward the boundaries of patient care. Thank you very much indeed for listening.
Thank you, Sonny.